Arun, I think we can start. Rahul,
Okay.
is it live?
Okay, sir.
Go live, sir.
Rahul? Yeah, okay. Arun, please go ahead.
Yes, sir. Good morning, everyone. Myself, Dr. Arun, consultant critical care, Medicover Hospitals, Hyderabad. Today, I am going to talk about landmark trials in sepsis. So, today we are going to hear about a lot of trials. So, to keep it interesting and for better understanding, I am going to follow this order. That is clinical question, evidence available, and current recommendation or practice. So first one is whenever we are receiving a patient either in emergency department or ICU with signs of hypoperfusion or shock, first line of management is administration of fluids. So this is a matter of debate since many decades. That is how much volume of fluid we should give. Current Surveying Sepsis Campaign Guidelines 2021 recommended to give 30 ml per kg of IV crystalloid within first 3 hours of resuscitation. And this recommendation based on retrospective data from the retrospective analysis and landmark trials of process, promise, and arise. Median volume of fluid patients received almost equal to 30 ml per kg. So based on this retrospective analysis, some other studies, this recommendation was taken. That's why they downgraded this recommendation from strong to weak in current surveying sepsis campaign guidelines. Second, during initial resuscitation, we all know we'll use lactate as a biomarker, and trends of lactates we'll observe, and that shows as a improvement in resuscitation. So where there is a resource limited settings where lactate also not available, is there any alternate for that? To address this, this study was done, that is Andromeda shock trial. Clinical question is, does the resuscitation strategy targeting normalization of capillary refill time compared with targeting serum lactate levels reduce mortality in patients with septic shock? So here, so population total 198 men and 226 women addressed in the ICU with septic shock, mean age of 63 years, and locations are 28 ICUs in 5 countries in South America. So total 427 patients randomized, and 212 are in peripheral perfusion group, that is CRT, capillary refill time, and 212 allocated to lactate group. And a resuscitation protocol of normalizing capillary refill time measured in seconds, and here resuscitation protocol of normalizing of decreasing lactate levels greater than 20% per 2 hours. So here primary outcome is all-cause mortality at 28 days. And findings of this study is all-cause mortality rate in peripheral perfusion group 34.9%, that is 74 patients died, and lactate group 43.4%, that is 92% died. There is no significant risk difference between these two groups with minus 8.4%, that is 95% confidence interval, minus 18.2% to 1.2%. So based on these results, Surveying Sepsis Campaign Guidelines 2022 recommended for adults with septic shock, we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. Next clinical question is target map. So this we quite commonly will give our orders to target map greater than 65 mm of Hg. So this is actually based on sepsis spam trial. This recommendation came. That is sepsis spam trial published in 2014. They compared higher map versus lower map. That is higher map 80 to 85 mm of Hg and lower map of 65 to 70 mm of Hg. By targeting these two groups, what they identified is it didn't affect any mortality between two groups. And in patient, another observation in this trial is in patients with chronic hypertension, targeting higher MAP, that is 80 to 85 mm of Hg, reduce the need for renal replacement therapy. After in 2014 sepsis spam trial published, after that some post hoc analysis also done, that also published. Those results were also published. Among those, a few important clinical questions, sir. One is we are of course we are targeting map of greater than 85 targeting map of greater than 65 mm of Hg. Is this sufficient to maintain cerebral perfusion? And hypothesis what they made in this post-hoc analysis is that a higher MAP target in patients with septic shock may improve level of arousal. For this, they included patients who were mechanically ventilated and sedated. To assess the sedation scale, they used ROS, that is Richmond Agitation Sedation Scale. And the observation was MAP target of 80 to 85 mm of Hg. That means higher target MAP group was associated with higher arousal level as compared to 65 to 70 mm of Hg, that is lower MAP group. And another post-hoc analysis is already in sepsis spam trial, we know chronic hypertensive patients targeting higher MAP that reduces the requirement of renal replacement therapy. Here again, they assessed before admitting this chronic hypertensive group, before admitting to the ICU, what antihypertensive they are on, and in case patients are in angiotensin 2 receptor blocker, will it get any benefit? So that observation is septic shock and chronic hypertension treated with angiotensin receptor blocker, that means before admission to the ICU, may benefit from a high MAP target to reduce the risk of AKI occurrence. And another post-hoc analysis is they compared with low MAP target and high MAP target, that whether it this targeting map altered the modeling score or lactate course, but it didn't show any difference. And another observation is compared to arterial lactate, modeling duration appears to be better marker of mortality. So based on this sepsis spam trial, we are targeting a map of greater than 65 mm of Hg. And it is reasonable to target in patients with chronic hypertensive slightly higher maps, which shown benefit in terms of reduced RRTs. Next clinical question is, already we discussed volume of fluid, how much to give in. Then another question is what type of fluid should give, whether crystalloids or colloids. In case of crystalloids, again, is it normal saline or balanced crystalloids? So this is also a matter of debate since many decades. First, I'm going to discuss about crystalloids versus colloids. If you see in 2012, success trial was published. In these patients with severe sepsis who received fluid resuscitation with hydroxyethyl starch compared with Ringer's acetate had a higher risk of death within 90 days and were more likely to receive renal replacement therapy. That means hydroxyethyl starch, this group, it showed who received this HAS shown higher mortality, and even RRTs also increased. Chest also shown similar kind of results. Here also they compared HAS versus saline. And at the same time, Crystal trial published among ICU patients with hypovolemic and septic shock, there was no mortality benefit at 28 days with colloids or crystalloids for resuscitation. This is again, this Crystal study results were criticized, and it has a lot of limitations. One major limitation is this study recruitment happened for more than 9 years. And in success and chest, they compared HES versus saline. That is, they compared one particular colloid. On the other hand, in Crystal, they compared the group of colloids like HES, gelatin, and included albumin also. Because of all these reasons, this this trial was criticized for its results. So after this trial success and chest, HES was out of picture. We are not using on regular basis. And coming to albumin, SAFE trial was published in 2004. That is a use of 4% albumin versus 0.9% sodium chloride for fluid resuscitation in critically ill patients. Results in similar outcomes at 28 days. And a non-significant trend in favor of albumin in sepsis and saline in trauma was observed. Then in 2014, Albios trial was published. Here, among patients with severe sepsis or septic shock, daily administration of albumin to maintain serum albumin of greater than or equal to 3 grams per deciliter was not associated with a reduction in all-cause mortality at 28 days when compared to no albumin. And another trial still recruiting, that is ARISS. So, next is coming to crystalloids. Among crystalloids, normal saline balanced versus unbalanced crystalloids. So SALT published in 2007, sorry, SPLIT published in 2015. that among patients receiving crystalloid fluid therapy in ICU, the use of buffered crystalloid compared with 0.9% normal saline did not reduce the risk of AKI, RRT, or in-hospital mortality. And so 2017 SALT was published. This shown it is a pilot cluster randomized crossover trial. Smart comparing saline to balanced crystalloid in the ICU. There was no difference in MAKE30. That means major adverse kidney events in 30 days. And basics and plus. This after surveying sepsis campaign guidelines, that is, which was published in 2021. Basics and plus were published, and these two studies also didn't show any greater benefit by using balanced crystalloids. So based on all these trials, trials suggesting superiority of balanced crystalloids are SMART trial, SALT ED trial. Trials didn't show any difference between normal saline and balanced crystalloids or split trial, SALT trial, basics, plus. Instead of to date, no study has shown that saline is superior to balanced crystalloid. Whether based on all these trials, what you can say is whether balanced crystalloid, some groups are showing benefit, and sometimes studies are showing there is no significant difference. At the same time, no study shown that is saline is superior to the balanced crystalloids. Then balanced crystalloids are so if you ask a question which is better, crystalloids versus colloids, that means simple answer is crystalloids. So that doesn't mean colloids are completely out of picture, and colloids also in certain specific conditions still useful, that is particularly albumin. Coming to balanced crystalloids, which are preferable in patients with metabolic acidosis, hyperchloremia, those are at with risk of renal injury or with raised creatinine. And normal saline is preferable in patients with metabolic alkalosis, hypochloremia, and cerebral edema. And albumin is recommended in sepsis, that's in surveying sepsis sample guidelines, they recommended patients who are requiring a large volume of resuscitation to reduce the fluid overload and its consequences, albumin can be used. But they didn't define after giving how much of crystalloids albumin should be added. And another indication for albumin is spontaneous bacterial peritonitis, hepatorenal syndrome, and large volume paracentesis. And post hoc analysis of SAFE trial revealed that the albumin administration associated with increased mortality in patients with traumatic brain injury. Next, we discussed about type of fluid which to be used. Now, restrictive versus liberal fluid management. What is the evidence available? So in this regard, we have two major trials. One is classics, another is Clovers. Here I am discussing about Clovers, which is a recent one that is published in NEJM in 2023. Clovers, they compared restrictive versus liberal fluid strategy. This is US based, it multi-center study, but conducted in US only, around 60 centers. And adult patients with suspected or confirmed infection included, and patients with systolic blood pressure of less than 100 mm of Fg or MAP less than 65 mm of Fg after receiving 1 liter, that is 1000 ml of fluid. Primary outcome here, taken as a death before discharge home by day 90. In restrictive fluid strategy group, they observed 14% and liberal 14.9%. Absolute difference is 0.9%, which is 95 confidence interval is 4.4 to 2.6, minus 4.4 to 2.6. And IV fluid administered over 24-hour period is in restrictive group 1267 ml and liberal group 3400 ml. So difference is 2134 ml. And duration of vasopressor used during first 24-hour period. In restrictive group, that is 9.6 hours. In liberal group, 5.4 hours. And they concluded the study as a restrictive fluid strategy with earlier vasopressor use did not result in significantly lower or higher mortality before discharge home by day 90 than a liberal fluid strategy. But it has a lot of limitations. One is this is conducted in US only. Its external validity is questioned. Second, 12,276 patients met inclusion criteria, and 4861 met eligibility criteria. But among those, they taken only 1,563 due to various reasons. This can lead to selection bias. And ICU admission rate, if you see, only 63% required ICU admission in this restrictive fluid group, and 60% patients only on vasopressors. This is telling us this group, these patients are not that much sick. And volume of fluid, body weight. They didn't consider the body weight, just they taken only volume of fluid. For example, for a patient with 50 kg, providing 2 liters of fluid and 100 kg providing 2 liters of fluid makes a difference, but they didn't consider the body weight also. These are the limitations in this Clover study. Current surviving sepsis campaign guidelines, that is, which was published in 2021, that didn't recommend one over other because of lack of solid evidence. Then coming to another clinical question, optimal timing of introduction of vasopressors. Previously we were following, first we will give 30 ml of per kg of fluid, then if patient not responding or still hypotensive, then starting off vasopressors. Now later this practice was changed. Simultaneously, along starting with fluid resuscitation, even vasopressor also are initiated. What is the evidence for this? If you see, there has not been any large prospective studies. Only a few studies are there. Among those, this refresh trial is a pilot trial, followed by sensor trial was published. Early use of norepinephrine in septic shock resuscitation, that is sensor trial, randomized trial. This was published in ATS Journals in 2019. So this is the primary outcome: shock resolution at 6 hours. In early norepinephrine group, there is sample around 155 patients, 76.1% they observed. In standard or conventional group, they observed 48.4%. So there is significant difference they observed. So even our practice now, simultaneously with the IV fluids, start vasopressors. It's not like give 30 ml per kg if it's not responding, then adding vasopressors. That practice now it changed. And early norepinephrine was associated with increased shock control at 6 hours. And on limitation in this study is patients received similar medium volume of resuscitative fluids. Early, our intention of starting early norepinephrine is requirement of amount of fluid should be reduced so that we can prevent consequences related to the fluid overload. But this outcome was not achieved in sensor trial because both groups received almost similar medium volume of resuscitative fluids. And coming to choice of vasopressors, in surviving sepsis campaign guidelines 2014, they recommended norepinephrine or dopamine through CVC. Then in 2013, SOAP2 trial was published. This is a large RCT, sample size of 1679. And they compared norepinephrine versus dopamine. And primary outcome is that 28-day mortality, they didn't observe any difference. But in dopamine group, they observed high risk of arrhythmias. And followed by this, many systemic review and meta-analysis, that is including of 11 RCTs published in 2015, norepinephrine has a better hemodynamic profile and a low risk of adverse events and overall mortality rate. And so based on all this SOAP2 trial and systemic review and meta-analysis, norepinephrine became the first choice of vasopressor in patients with sepsis and septic shock. Then if patients with septic shock, second one is if after starting norepinephrine, patients are not responding, which vasopressor to be added? This is another important clinical question. To address this, two landmark trials are published previously. One is VAST, another one is VANISH. VAST published in 2008, VANISH in 2016. VAST trial, they compared norepinephrine versus norepinephrine plus vasopressin. Here, they didn't observe any mortality in 28 days, but subgroup analysis showed a trend toward lower 28-day mortality in norepinephrine plus vasopressin group. And VANISH in 2016 it was published. They actually compared norepinephrine and vasopressin. In vasopressin group, they observed lower rate of RRT. Based on these trials, current recommendations are start vasopressin when the norepinephrine dose reaches to 0.25 to 0.5 mics per kg per minute. And another vasopressors and anadrops also was in research. In this recent guidelines, they recommend against using of terlipressin, and for angiotensin 2, serlipressin, phenylephrine. To recommend these drugs, there are no solid. There are no sufficient data available. Coming to epinephrine, when there is norepinephrine is not available, we can use it as alternative. This is one indication. Second one is patients with sepsis, septic shock, and with cardiac dysfunction. We can use norepinephrine and plus dobutamine combination or epinephrine alone. That is the Surviving Sepsis Campaign guideline recommendations. So this is the list taken from SSC 2021 guidelines. That is already what we discussed. The same thing here in one picture I'm showing here. So use norepinephrine as first-line vasopressors and target MAP of 65 mm of Hg. Consider invasive monitoring of arterial blood pressure. Consider initiating vasopressor peripherally when central line is not available. If you are initiating through peripheral line, it should be proximal to the antecubital fossa. Consider adding vasopressin if a patient is not responding to norepinephrine. And in case of cardiogenic shock or cardiac involvement, consider adding dobutamine or switching to epinephrine. Then coming to steroids in septic shock. So steroids in septic shock, if you see, way back from 1950 onwards, we have some studies on this particular issue. But 1950 to 1980, there are only few small RCTs with contradicting outcomes. In 1990s, 1980 and 1990s, two large multicenter studies, which data was published, they used methylprednisolone 30 mg per kg and observed the patients who received steroids. They observed higher mortality. So IDSA recommended against using of steroids in septic shock in 1990s. So from 2000 onwards, that picture was changed. That is 2000, Anane et al., Corticus, Adrenal, these trials are published. Anane et al., 2002, this study was published. That is corticosteroid group, 50 mg per 6 hours IV and fludrocortisone 50 mics daily enterally for 7 days. So here no difference in the overall mortality at 28 days. Vasopressors is earlier in the treatment group. And Corticus published in 2008. Hydrocortisone 50 mg per 6 hours for 7 days. And outcome is no difference in the 28-day mortality. Earlier shock levels are observed in hydrocortisone group. Then after 1 decade, that is adrenal and approaches came into the picture. Adrenal trial, corticosteroid group, they received hydrocortisone as a continuous infusion of 200 mg per day for 7 days. Here also they observed earlier shock resolution and discontinuation of mechanical ventilation and ICU discharge with hydrocortisone group. And approaches, that is also published in 2018. Hydrocortisone 50 mg per 6 hours IV and fludrocortisone 50 mics daily enterally for 7 days. Outcome is 90-day mortality, all-cause mortality at ICU, hospital and discharge, and at 180 days significantly lower with the corticosteroid group. So after this adrenal results of adrenal and approaches driven 2021 Surviving Sepsis Campaign guidelines, they recommended to use steroids in patients with septic shock. That is 200 mg per day of hydrocortisone given as a 50 mg IV every 6th hourly or as a continuous infusion. When patients requirement of vasopressin, that is norepinephrine or epinephrine for at least 4 hours after initiation and dose of greater than or equal to 0.25 mics per kg per minute, this is where we should start or add this hydrocortisone to the ongoing treatment. And another question here is, if a patient is present with sepsis but didn't develop septic shock, by initiating steroids, can we prevent the septic shock? This question addressed by Hypres, which was published in 2016. There, the time there was the term severe sepsis. Now, after later date, that was removed and converted into sepsis, septic shock. These two terms only. So the severe sepsis they included, and they observed by adding steroids in those group, can it prevent development of shock, but it didn't show any difference. So another question in this regard to steroids is whether adding fluorocortisone to hydrocortisone will a patient get any benefit? To answer this question, at present there is no strong strong studies or RCTs are available. Next, next clinical question is about HAD therapy, that is hydrocortisone, ascorbic acid, that is our vitamin C, and thiamine therapy. So already we discussed about hydrocortisone role in hydrocortisone role in septic shock. Then what about this vitamin C and thiamine? Why it came into the picture, particularly in regards to septic shock? Because ascorbic acid has properties like antioxidant, anti-inflammatory, cortisol sparing, nitric oxide synthase inhibitory, and increasing catecholamine synthesis. On the other hand, thiamine, it is a necessary cofactor for important metabolic enzymes like PDH, that is pyruvate dehydrogenase and transketolase. This PDH plays important role in Krebs cycle and aerobic respiration. Its defect leads to excessive production of lactate due to anaerobic respiration. And transketolase helps in generating antioxidants. Thiamine deficiency may lead to this loss of antioxidants also. So that's why this ascorbic acid and thiamine also come into the picture. So in 2017, Marek et al. Proposed this Marek cocktail or Marek protocol, that is hydrocortisone 50 mg 6 hourly, thiamine 200 mg 12 hourly, and vitamin C 1.5 grams 6 hourly. And outcomes are they observed hospital mortality. There is significant difference between control group and treatment group. In control group, mortality is 40.4% and treatment group 8.5%. That is, p-value is significant, less than 0.001. Other statistical significant things are time on vasopressin per hours and delta SOFA at 72 hours, delta progesterone clearance at 72 hours. So after this trial, even this Marek protocol gained media and public attention. It's become popular during that time. But later date, some other trials published this question, this Marek protocol, and the combination of all these three components. Because we already know steroids show beneficial in septic shock patients. Because of that component patient getting benefit, or really it is showing synergistic effect, that is vitamin C and thiamine along with hydrocortisone. It is difficult to differentiate based on these results. So vitamins trial was published later date. Here clinical question is, does vitamin treatment with this cocktail, that is vitamin C, hydrocortisone and thiamine versus hydrocortisone alone. And they concluded the findings of this clinical research that the vitamin C, hydrocortisone and thiamine in this cocktail does not lead to a more rapid resolution of septic shock compared with IV hydrocortisone alone. After vitamins trial, this 2021 Surveying Guidelines issued a weak recommendation against IV vitamin C based on low quality evidence. And after surveying sepsis campaign guidelines also, some trials published, that is Victus, it showed no difference in mortality, and Lovit trial in 2022. And this showed higher risk of death or persistent organ dysfunction at 28 days in vitamin C group. But if you see all these study results, what we got from higher income countries, whether can it be applicable in low income countries? Because there may be deficiency in these low income countries groups, this population vitamin C deficiency. So whether we can apply these results here is still questionable. Next, delivery of antibiotics. So SSC 2021 guidelines recommended for adults with sepsis or septic shock, suggest using prolonged infusion of beta-lactams for maintenance over conventional bolus infusion. So because time dependent, on other terms, time-dependent antibiotics, they recommended to use prolonged infusion over intermittent doses. So if you see evidence for this study, one study recently published, that is continuous versus intermittent meropenem administration in critically ill patients with sepsis. That is MERCY randomized control trial. It is published in JAMA 2023. So this is a double-blind RCT. So one group, that is continuous group, they receive 3 gram over 24 hours infusion. Other groups, that is intermittent group, they receive 30 to 1 gram TID. That means 30 to 60 minutes they will receive as an infusion. So composite outcome of all-cause mortality at day 28, this is the primary outcome. In continuous group, they observed 47%, and intermittent group 49%. Another primary outcome in this trial is emergence of extensive drug resistance and pan-drug resistant bacteria at day 28. This is also statistically not significant. So it didn't improve the composite outcome of mortality and emergence of pan-drug resistance or extensively drug-resistant bacteria at day 28. But it has some limitations too. So when, for example, patient receiving meropenem and developed AKI, so the dose adjustments were done, and based on a physician or clinical discretion, they can change the doses. Second limitation is routine therapeutic drug monitor of meropenem was not done. Then another important confounding factor in this trial is, along with meropenem, patient can use other antibiotics which can affect the patient's improvement. That didn't take into account. These are the other limitations. So we need further studies to say whether continuous is better than intermittent. Next trial is on using of polymyxin B hemoperfusion, particularly when patients with sepsis or septic shock. Instead of all using conventional method, fluids, vasopressors, steroids, and what all we discussed, after not improving, one important reason for that not improving patients is cytokine storm and increased levels of endotoxins. By using this polymyxin B hemoperfusion, removal of endotoxins, whether it will be helpful, and with that, can we reverse the septic shock? To evaluate that, this study was done. Effects of targeted polymyxin B hemoperfusion on 28-day mortality in patients with septic shock and elevated endotoxin levels. This is published in JAMA in 2018. So primary outcome is mortality at 21 days. This was done in 55 tertiary hospitals in the United States and Canada. And before using, they assessed the blood endotoxin levels. If it is greater than 0.6 or higher, they included in the study. And this primary mortality in polymyxin group, they observed 37.7%, and liberal group, other group is 34.5%. And in patients with multi-organ dysfunction also 44.5% and 43.6%. So they concluded the study, polymyxin B hemoperfusion treatment plus conventional medical therapy compared with conventional therapy didn't reduce any 28-day mortality. But problem with this study is to enroll 450 patients, it took almost 6 years time for them. And the dose, timing, and duration of hemoperfusion also uncertain. So it and and another thing is, we know endotoxin plays a major role when patients are not responding to the cytokine storm and endotoxin, when patients are not responding to the conventional methods. So still there are a specific subgroup of septic patient may get benefit with this polymyxin B hemoperfusion. For these, further trials are required. Thank you.
Ghanshyam.
Hello.
Hello, Ghanshyam.
Yeah. Thank you, Arun. I am not aware if there have been any major trials done recently on the point of early identification of sepsis, because that is one area where we have always had some problems. If you see, majority of the trials have been done extensively in resuscitation, or trials where we try to look at modifying the inflammatory response. Srinivas, are there any trials which have looked at the early identification of sepsis? Use of molecular diagnostics? Hello?
There are ongoing trials, Ghanshyam, on early molecular diagnostics. Yes, there are a lot of Chinese studies which have looked at molecular diagnostics for the early diagnosis of sepsis, but the credibility is a little doubtful. Having said that, I think the SOFA 2 scoring is going to be released very soon. That is probably going to define the early clinical identification of sepsis. I think the fluid resuscitation again remains a big issue. The so-called 30 mils per kilogram for every patient doesn't seem to be the right strategy for all patients. It may be a more conservative fluid. So there are some studies going on early conservative fluid strategy versus this conventional 30 ml per kilogram body weight. A lot of interest again in methylene blue in advanced vasodilatory shock. Couple of randomized controlled trials published last year, but nothing that unequivocally says that if the patient is on NORAD, vasopressin, still hypoperfused, you should start methylene blue. I think still, but day before yesterday, there was a publication on an approach to sepsis from a symptom-based approach to from a symptom-based approach to a system-based approach, which we have shared in the Higgs group. I think that's a good understanding because now we understand that sepsis is not a single disease. It is 4 phenotypes, the alpha, beta, delta, and gamma phenotypes, each with a different set of manifestations, with hepatic manifestation predominant in one phenotype, renal manifestations in one phenotype, respiratory failure in one phenotype, and coagulation in the other phenotype. So our approach, our strategies, our protective strategies have to be tailored according to the area of work is probably going to be on the phenotypic classification with the application of machine learning platforms. This is where I think sepsis will be 5 years from now.
Okay.
I think it's an excellent presentation, Arun. Very crisp and summarized what is relevant right now and what we have to do in practice. So please do join us again next week for another session on the Higgs platform. And those of you who have any queries or comments, please do post them on the group from where you got this link from, and we will try to answer them at the end. Thank you very much for joining. Have a good day.
Thank you, Srinivas sir. Thank you, Ganesham sir.